I'm called Ngekubek Intazo, and actually I'm a fifth year medical student in the Faculty of Health Sciences, University of Buea, Cameroon. And it's a privilege to be here and to do this particular presentation. So actually, this is a junior club, and in the junior club, it's not like it's not just about coming to present, but it's about a discussion where all of us go through the paper and we discuss and we share ideas about the paper. So we today we'll be talking on this article titled "Traumatic Brain Injury in Cameroon: A Prospective Observational Study in a Level 1 Trauma Center." So actually, this article was published. This is the information about the article. I'll try use my mouse uh, to indicate where when I'm doing the presentation. So the article was actually published on the 28th of this August, and it was published in the Journal for Multidisciplinary Digital Publishing Journal. So the research was done by a group of researchers, neuroscientists, and researchers. So about traumatic brain injury in Cameroon. So for this presentation, for us to navigate through this presentation, we are going to use this guideline to go through the paper, and yeah, we'll use this plus academic peer-reviewed guideline to go through the paper. So we'll talk about the abstract, that is the various sections of the paper. We'll talk about the abstract title and references. After that, we'll go to the introduction and background. Then we'll move to methods. Then we'll go to results, discussion and conclusions, and that will be all for the presentation. So when looking at each of the sections of the paper proper, we are going to see if all the questions or what are supposed to be addressed in each section has been addressed or not. So we'll go back to our paper. Okay, so let me enlarge it. Okay, I hope everyone can get my can see my screen. Hello, are you put there?
Yes, we can see your screen.
Yes.
Okay, okay. So before I start, as I said earlier, it's a junior club, so well, at least we're supposed to go through the paper and before coming, so that at least it will be some sort of idea sharing. We are communicating, we are sharing ideas. So I would like to know those who actually went through the paper before, or who actually went to the paper to see what he's talking about. Please, if you went to the paper, maybe you can just indicate, or you can just indicate. Okay. It seems no one went through the paper. All right. So we'll start with the abstract. Actually, at the abstract in any research paper is like a summary. Actually, it's like a summary of all what you are going to see when you start reading the paper proper, from the introduction right up to or the discussions and the conclusion. So we'll look at the abstract, and there are various aspects that must be touched in the abstract. So this abstract is we'll look at the background and objectives, we'll look at the materials and methods, and then we'll go to the results and then conclusions. So the objectives of generally is a speculation that about 14 million people we suffer from traumatic brain injury by the year 2050. So it's actually a call for concern as far as health policy is concerned. So the aim of the project, of the aim of this, the objective of this project is to study, to define the features and outcomes of traumatic brain injury in patients over 1 year period in a level 1 trauma center in Cameroon. So the objectives for which this work was done was clearly highlighted here.
Excuse me, Beckley. I think we're unable to see your slides. You can just try to share the screen
Okay,
again.
okay. Thank you very much. So the objective of the study was clearly outlined, and it is the features and the outcomes of traumatic brain injury patients see over a period of 1 year in the level one trauma center. So for the materials, the data was gathered on demographics, causes, clinical aspects, and discharge status were collected over a period of 12 months. And after that, a Glasgow coma outcome scale extended and the quality of life questionnaire after brain injury was used to evaluate the outcomes of the patients. Like after the patients were being discharged, they were being followed up from a distance using the quality of life questionnaire after the traumatic brain. Like I said, the abstract is just a short summary of what we are going to see throughout the paper. So, so generally, there's actually a speculation that about 40 million people will suffer from traumatic brain injury by the year 2050. So the objective of this study was to define the features and outcomes of traumatic brain injury patients over a 1 year period in a level one trauma care center here in Cameroon. So the data on demographics, causes, clinical aspects, and discharge status were collected over a period of 12 months and from 160 traumatic brain injury patients. And the results on the causes of TBI were as follows. So the results were as follows, and the road traffic accident accounted for 85% of the causes of traumatic brain injury. Assaults accounted for 7.5%, and falls from height and from various aspects, especially in the elderly, accounted for 2.5% of the traumatic brain injury patients. And there was lack of pre-hospital care, financial constraint limiting both CT scan and medical care, and the lack of acute physiotherapy services were also reported in this study. So uh, briefly, that is it about the abstract. And from the guide, the plus guide, I think all the requirements that are supposed to be on the abstract are there. Like the first is the aim of the study clear. I think the aim of the study is clear. At least they clearly stated why they did that particular study. The next was, is it clear what the study found and how they did it, how they did the study. Yeah, the the results they got after the study was clear. They spoke about road traffic accident, assaults, and falls as the causes of traumatic brain injury that were identified in these 160 patients. The next is if the title is informative and relevant. Actually, from what we have seen so far, the title of this project is informative and is relevant in the sense that there is limited or no data as far as the outcomes, that's the clinical outcomes of traumatic brain injury patients are concerned in Cameroon, and not only in Cameroon, even in other countries in Africa and the world at large. And are the references relevant, recent? If you look at the references for this paper, I think the references were relevant and they were recent, and the references were even in correlations with some of the findings that were identified in the paper. So that is it for the abstract. So we'll go now to the paper proper, and the paper proper, and we'll start with the introduction. Now, the traumatic brain injury is actually a global burden because it one of the is considered one of the main public health challenges, as it is the leading cause of death and disability globally. And also in sub-Saharan Africa, an estimated 3.2 million people sustain traumatic brain injury annually, and this number is expected to rise to 40 million by the year 2050, as we have seen already in the abstract of the paper. And they are saying here that the traumatic road traffic accidents, falls, and assaults are the most common causes of traumatic brain injury that were identified in this patient. So globally, traumatic brain injury is a global public health challenge affecting about 69 million individuals annually. So they are talking about the epidemiology globally. After that, they moved to the epidemiology regionally, that is in sub-Saharan Africa, and then they spoke about the epidemiology nationally, that is the case of Cameroon. So it is also the leading cause of death and disability worldwide. Regionally, in sub-Saharan Africa, an estimated 3.2 million people sustain traumatic brain injury annually, and this is expected to rise to 40 million. The road traffic accident, falls, and assault were also identified as the main cause of traumatic brain injury in the in sub-Saharan Africa, and especially in low and middle income countries, like the case in Cameroon. Or now the third paragraph now is talking about despite the social and economic aspect of the economic impact of traumatic brain injury in Cameroon, data on its characteristics and medium or long-term outcomes are lacking. Only a few studies from sub-Saharan Africa report traumatic brain injuries in a major cause of death and as a major cause of death and disability. So due to the lack of data concerning the outcomes of the characteristics and outcomes of traumatic brain injury in Cameroon. That is one of the main objectives why the the authors decided to do this particular research. So the aims the aims and objective of the this particular paper is also further explained in this particular paragraph. I say furthermore, the study of Dube R, which was cited at the reference number 14, was retrospective in design. Now, retrospective study is like you have a flashback, like you go back and see what happened maybe 5 years ago or 6 years ago, and like that you cannot actually have a clear picture. But when you're looking at a prospective study, like what they did here, like you receive the patients and then you monitor them over a period of time. Like in this case, they monitor the patients over a period of 1 year. That's from 2021 to 2022. So that is one of the main strengths of this particular paper. Then the study seeks to provide patient characteristics and medium-term outcomes with the class 4 outcome scale extended. And this class 4 outcome scale is actually using categories which are broader and less sensitive to change. So this scale was used in this level 1 trauma center to evaluate the patients that were being enrolled into this particular study. So the study was conducted in Douala, that's a particular a city in Cameroon, and it was done in Douala in using 160 traumatic brain injury patients. And we should also note that actually Cameroon is one of the most is actually part of low and middle income countries. So that is it for briefly for the introduction, and I would like us to have a review again on the pupils guide to see if this introductory part of the paper actually stress on what they are supposed to talk about. So the first is it clear what is already known about this topic? Yeah, actually, I think it's clear because they have already discussed about the epidemiology of traumatic brain injury in. They spoke about it in the US. They spoke about the epidemiology in sub-Saharan Africa, and then that's usually now in nationally in the case of Cameroon. They also mentioned the fact that there is limited data about the characteristics and the outcomes of traumatic brain injury patients. The next is the reason is the research question clearly outlined. Yeah, we have seen here that the research question was clearly outlined. That our study seeks to provide patient characteristics and medium long-term outcomes with the Glasgow outcome scale extended. So the research questions here for me has been outlined. So is the research question justified given what is already known about the topic? Yeah, I think the research question has been justified. Like they've already given what is already known about the topic, and they went further to give the lapses as far as research concerning this particular topic is concerned in Cameroon. So I think the research question has been justified. So briefly, that is it for the introductory part of the article. So I would like to give the floor if there are any questions or there are any contributions as far as this section is concerned.
To the audience, if there are any questions, you can please feel free to ask. And alternatively, you can type through the messages. So I'll encourage our presenter, as we are presenting, maybe you can be checking through the messages if people have posted through some question. Sure.
Hi, how about you can finish the presentation and then we can have questions and discussions at the end. How's that?
Oh, sorry, I didn't get you clearly. I don't know. Maybe you can type. Please, uh, the questions or the contributions should please just permit. Just bear with me. Maybe you can type so that I can easily flow with you. Please, if you don't mind.
All right, sure. Yeah, so the thing is, you can type your question, then the questions will be answered at the end of the presentation. Then we'll have a Q&A session at the end. So you can just continue the presentation, then we'll have a Q&A session at the end. Sure.
Okay. Okay. Oh, so we are done with the introductory part of the paper. So we'll move now to the methods, that's the materials and methods. So under the materials and methods, we'll talk about the study design that the authors they used. We'll talk about the study population, we'll talk about the inclusion and the exclusion criteria. We'll talk about data collection and so on and so forth. So this particular study, they did a prospective cohort study on traumatic brain injury patients attending a level 1 trauma center in a hospital in Cameroon. So, like I explained before, a prospective study is like you observe, you sit and then you observe what is happening currently. You observe what is happening currently throughout the particular period of time, and they actually did this. This study in a period of 12 months. So the study was done from January 2021 to February 2022, giving a period of 12 months. And the town in which it was done is Douala. That's the name of the city, Douala in Cameroon. So it's actually on the Atlantic Ocean and is the economic capital of the country. So that is just an aside or concerning this, and it has a population of approximately 4 million people. So the level 1 trauma center that this research was done actually is among the few centers in Cameroon that has expertise for traumatic brain injury care, and also have a fully functional neurosurgical unit with 4 neurosurgeons, and then a CT scanner and a 0.5 Tesla magnetic resonance imaging. So to some extent, the center in which this study was done has the capacity to actually take care of traumatic brain injury patients. So moving now to the study population, actually this study included 120 traumatic brain injury patients, but there were some inclusion and exclusion criteria. for this particular study. So there were inclusion and exclusion criteria for this particular study. Like for example, those who were included are those who had the injury less than 24 hours, like in between the time of injury to when they came to the hospital in is within 24 hours. So those who had injury, those who came after 24 hours were excluded from the study. And also those who had pre-existing neuropsychiatric problems were also excluded from the study, as well as thieves were also excluded from the study. So those were the inclusion, and the inclusion criteria was those who had traumatic brain injury and who came to the hospital within 24 hours after the injury. For the exclusion criteria, those who had traumatic brain injury after 24 hours, that they presented in the hospital after 24 hours, were excluded. And then those who has pre-existing psychiatric problems were also excluded, as well as thieves. So for the data collection, after a definitive diagnosis of traumatic brain injury, the study purpose was meticulously explained to the patient. Of course, you cannot include a particular patient for a study without at least getting the consent and the approval from the patient. It would be illegal for you to do that. So they actually get after the diagnosis of traumatic brain injury, they discuss with the patient, they explain the procedure and about the research to the patients, and they get the consent of the patient before they included them in among those that they will use for this particular study. So data collection was based on the National Institute of Health and the National Institute of Neurological Disorders. So common data elements and included information such as socio-demographic characteristics. So information concerning age, sex, profession, marital status, religion, and nationality. Also the money income, so as to to evaluate the socioeconomic status of the patients. The clinical details too, like the heart rate, the blood pressure, temperature, Glasgow Coma score, were also recorded. The neuroimaging findings for those who were able to afford neuroimaging were also recorded. Pre-hospital factors like transport, the means of transport, if it was medicalized or non-medicalized means, were also recorded. Now, some of the information that they get that concern the clinical details, like the blood pressure, the temperature, they were actually defined. They were actually defined like the hypothermia, that's low blood pressure, was defined as temperature less than 35 degrees Celsius. Normal was between 35 to 37.5. So sorry, 35 to 37.9 degrees Celsius. And fever was considered a temperature of greater than 38 degrees Celsius according to CDC, the Center for Disease Control and Prevention, 2019. So hypertension was also noted as blood pressure below, that's systolic blood pressure of 90 and the diastolic blood pressure of 60 millimeters of mercury. So the values of 180 to 138 to 100 or 138, 139 on 80 to 89 was considered stage 1 hypertension, and then greater than 140 and on 190 was considered stage 2 stage 4 hypertension. Also, the traumatic brain injury severity was also classified based on the Glasgow Coma scale. As we all know, we can classify traumatic brain injury based on if there was loss of consciousness, the duration of loss of consciousness, and the Glasgow Coma score. So they classify it here based on the Glasgow Coma score, and they gave a score of 3 to 8 for severe, 9 to 12 for moderate, and 13 to 15 for mild traumatic brain injury. So they also included a etiology of the traumatic brain injury, the injury mechanism, presenting symptoms, the hospital length of stay, and the outcomes of the patients. So they also included they also did the quality of life questionnaire after brain injury were also recorded for 6 months after hospital discharge. Like I said, they did this particular study for 1 month. So after the patient were discharged, they followed them throughout a period of 6 months using this particular questionnaire to evaluate their outcomes. So they did this follow up using telephone communication with the parents as well as their families, with the parents and their families. So they did, and this included good recovery, mental health, physical disability, vegetative state, death, and the data was collected and reported in accordance with the stroke guidelines. So we are going to see the table down. Now the outcome measures. For the outcome measure, the discharge status were scored using the disability rating score. So this score was used to evaluate the discharge status. But the total score was 29. So level of disability for the patients who never had any disability, they were given a score of 0. Those who have disability of 1, they were given a score of might. The score of 1 for might. Those with the score of 2 to 3 was for partial. Those with the score of 4 to 6 was moderate. Those with the score of 7 to 11 was moderately severe. Those for 12 to 4 to 16 was severe. 17 to 21 was extremely severe. From 22 to 24 was vegetative state, and from 25 to 29 was extreme vegetative state. So this disability rating scale was completed on the day of discharge. That's following, including those who were discharged against medical advice, and the patient's welfare was inquired about at 2 and 12 months after discharge. So they inquired the welfare, how the patient were faring at 2 months and at 4 months. That's after they were discharged and they were released to go home. So the 6 month outcome evaluations were performed with the structured interview uh, for the Glasgow outcome scale extended. So they evaluated death, those who died, vegetative state, lower or upper severe disability, upper and lower moderate disability, or good recovery. So in the majority of the cases, the 6 month outcomes were completed by telephone interviews, because since this was due to the fact that most of the patients were living in far away areas, and so in order for the researchers or the authors to actually get in contact with the patients, they had to to discuss with them using the telephone network, and those limited number of patients were actually the researchers were actually able to meet just limited number of patients in person and interview them. Now, to limit the bias of subjectivity on the part of the patient, the authors actually interviewed both the patients and the relatives. Like for example, maybe the patients are still, maybe they are not fully recovered from traumatic injury, and so they cannot actually answer the questions that the researchers were actually asking appropriately. So they have to get to the parents or to the guardian to actually get the proper information about the patients. So data management, move now to data management and analysis. The continuous variables were reported as median with 25, that's 25th and 75th percentiles, and the means and standard deviations were also calculated. Categorical variables were described as frequencies and percentages, as we are going to see in the tables that the researchers actually did. So comparisons between two categorical variables were done using the chi-square test or the Fisher exact test. And when the expected frequency was less than the expected frequency at the end of that statistical analysis was less than 5, and we are going to see it in the course of this presentation. So that is it for the methods and for the materials and methods. So we'll move now to our review template to see if the researchers actually, if the materials and method were actually good as far as this guideline is concerned. So the first aspect that we have to check is the process of subject selection clear? Of course, from what we have seen so far, the selection, the inclusion and the exclusion criteria for these patients were clearly outlined. That those who were included in the study and those who were excluded from the study. The next is, are the variables defined and measured appropriately? We have already seen all the variables, both the qualitative and the quantitative variables. They were the variables were defined and they were measured appropriately. Like they spoke about the temperatures or hyperthermia, that's fever. They spoke about the blood pressures, that's grade 1 hypertension, grade 2 hypertension. So the variables were defined and they were measured appropriately in this paper. Are the study method valid and reliable? Well, so far I think the study methods were valid and reliable. So the next is there enough detail in order to replicate the study? Well, I think there is enough detail in this paper to actually replicate this study. Like they can further do research on maybe in Nigeria, in Ghana, or in other countries, provided if they don't have data as far as this particular topic is concerned. So I think the paper is in detail. The I think there's enough detail, and the paper, the work can actually be reproduced or can be replicated in the nearest future in other countries where data about this particular aspect is lagging. So we'll move to the results. We'll move to the results. So for the result, I'll just move directly to the table and I'll explain the important findings. So for the age, those who were less than 15 years of age were six. That's, as we all know, 160 patients were actually recruited or they were enrolled for this particular study. So out of that 160, eight, sorry, six patients were the age of less than 50 years. Those between 15 to 45 years were 125, and we realized that if you look at it, you see that this is majority of the population, and this can actually be explained given the fact that the age between 15 to 45 years are actually part of the active population, those who are actively working and those who are exposed to strenuous activities, and those who are exposed to strenuous activities are easily exposed to to some of the causes of traumatic brain injuries that we have seen so far. So those between 46 to 65 years of age there are 22 of them, which gives a total number of a percentage of 14% out of 100, and those who are greater than 65% were 7 of them, that's 4.4%. And later we will see that those who were of age greater than 65 years, the cause of their traumatic brain injury will likely be fall from the high, or maybe fall from or maybe other aspects. Now for the gender, the number of females in this study were 16. The number of males were 144. Of course, the number of males have to increase because, as compared to the females, the males they are exposed to a lot of hazardous activities, and they are also part of the working population, as we have seen concerning the gender. So for the level of education, educated, those who graduated, that's out of the 160 traumatic brain injury patients that were recruited, 19 were graduates, nine were illiterates, 7 were those who actually matriculated. Those who actually graduated, that's postgraduate, that's those who have graduated from, maybe they have a degree from the university. We have only one patient. Those who were from, those who attend only primary education, they were 14. Those who attend secondary education were 82, giving the majority of the population there. And then those who were unknown, you have 2. Now, for the profession, that's among those who were recruited for this study, the profession, those who were employed in service, in service, maybe or they have these white collar jobs. There were 30 patients. Those were manual workers, who are exposed to maybe farming and others. There were 24 of them. And now those were bike riders, there are 43 bike riders. And of course, this further explains the reasons why traumatic brain injury is more common in bike riders than other professions. Now, those who are students, they are 16, like maybe they are passengers on the bike, the motorcycle, or the vehicle, and they are involved in the road traumatic brain injury. That's a road traffic accident that leads to traumatic brain injury. For those who are unemployed, you have 21 of them, and then the others are 26. So marital status, 67 of the patients were 67 of the patients were married. 6 were not applicable, 87 were single, giving the majority of the population. And of course, if you look at those who were involved in between 15 to 45 years of age, you see that that particular range of age group was predominant. So majority of those who are single will fall inside that age, and those who are single are part of the active population, and as such they are exposed to some of the causes of traumatic brain injury. So we look at for religion, those who are Christians, we have 122, giving the majority of the population that was recruited for this study. Those who are Muslims is 22, others is 2. So missing it, that those who they could not actually differentiate if they were Christians or Muslims or others. Now for the driving license, this is very, very important because it also greatly give the outcomes or the reasons why some of the patients had traumatic, they were involved in road traffic accidents also, and as the result of that, they had traumatic brain injury. So those who were having driving license were 11 of them out of 160. So you see that the number is really low. So those who had no license were 73 of them, which is uh, I think is the highest in the population, and this can actually give us the reasons why they were involved in road traffic accidents due to the fact that they had limited knowledge on how to use the roads properly. Those for non-applicable 70, then for non is 6. So we go down to income rate per month in Central Africa. Actually, we see that those who had an income rate of 78 to 234 US dollars were, majority of the population. That's 84 patients out of 160 that were recruited for this study. So we also look at the medical social issue like diabetes, hypertension, smoking, alcohol. So we will see that diabetes, only 2 patients had diabetes, 14 patients had hypertension, 22 patients had smoking, and alcohol consumption was noted in 97% of the patients. So we see that alcohol consumption is something that can greatly influence things like road traffic accidents for motorbikes, vehicles, and the others, due to the state of the driver or the bike rider. Now, this is a small guide. The applicable refers to traumatic brain injury patients who were drivers of either a motorcycle or vehicle at the time of injury. Unapplicable refers to traumatic brain injury patients who were not driving at the time they sustained the traumatic brain injury. So, clinical details of the patients. Now, the clinical details is talking about how the patients presented. Like some came with, loss of consciousness or headache, vomiting, nausea. So we'll just go directly to the table for the sake of time. So those who presented with loss of consciousness, 152 patients presented with loss of consciousness, consisting of 95% of the patients. So we see that majority of the patients that had traumatic brain injury, they presented with loss of consciousness. So those who also presented with vomiting, they were 55. Those who came with nausea, 22. Ear bleeds, nose bleeders, epistaxis, 43 of the patients. Those who came with headache, there were 103. Those who came with seizures were 7, agitation. And so for these clinical details, you realize that majority of the patients came with loss of consciousness, which consists of 152, and headache, which consists of 103 patients. So move now to blood pressure. So elevated, 15% of the 15 patients had elevated blood pressure. Uh, 62 patients had hypertension, maybe grade 1 hypertension, grade 2 hypertension, and then 19 patients had hypotension. That's blood pressure lower than systolic blood pressure of less than 90, that's only less than 60. So for the those who came with normal blood pressure, there were 64 of them. So we see that majority of them came with hypertension, maybe grade 1 or grade 2 hypertension. So for the temperature, you see that majority of the patients came with normal temperature, followed by elevated temperature, and they also have a missing value in 6 of the patients. Now, when the patients came to the hospital, actually, when they evaluated the pupillary reflex, both pupils were reactive in 145% of the patients. 145 patients giving 91%, which is a majority of the study population. Those who had no pupil reaction was 5. Those who had only one pupil reaction was 10, and then so we see that both pupil reactive was seen in 145 patients out of the 160. Now, when they assess the level of consciousness of these patients, they realized that for eye opening, majority of the patients had an eye opening of 4. That's a spontaneous eye opening. Majority of the patients had the eye opening of 4. That's 59 patients. We go now to verbal response. Majority of the patients had the verbal response of 4, and then the majority had the motor response of 6. So influence of alcohol. Now, this one can only be assessed during the history. That's when they were taking the history of the patient. That's when they were taking the history of the patient. So they realized that 108 never they never consumed alcohol prior to the injury that they had, and then the suspected number of those who consume alcohol were 33, which is relatively large compared to those that don't know, which is 9. So we move now to the injury details of the participants. Now, this injury details is about the cause of the traumatic brain injury, if it was a road traffic accident, if it was or if it was an assault, maybe the patient was caught in the act of theft and then was assaulted, and if maybe the patient had a blunt injury with a blunt instrument, and so on and so forth. So for the cause of injury for 160 patients, assault or violence was noted in 12 of the patients, giving that's 7.5% of the patients. Fall from height was 8%, so 8 of the patients. So, and we can notice that fall from height mostly in patients that are the age of, or that's greater than 65 years of age. Then road traffic accidents, of course, you see in 136 patients out of the 160, which is the majority in this particular study. So now we look at the road traffic accident types, because we have already seen that road traffic accident is the most common cause of traumatic brain injury, since majority of the patients had road traffic accidents. So the road traffic accident type, it was a pedestrian road traffic collision. So those who were walking along the road and they were suddenly hit by maybe a bike or maybe a motorcycle, there were 31 patients. Those for road traffic collision, maybe the bike collided with another bike, the motorcycle collided with another, there were 7 patients. Then the road traffic collision, cyclists will have 1. Road traffic collision, that's driver, maybe or maybe a car, that's a vehicular accident, like the 2 of them. And then motorcyclists 81, and then motorcyclists 81. Motorcyclists where the passenger is involved in the road traffic accident, that the passenger actually incurred a traumatic brain injury. We have 11 of the patients. And then traumatic road traffic collision order in other types of vehicle involving the driver, we have 1. So we also go for 4 of 4 type, and like I explained, we mostly experience this in patients greater than in patients with age of 65 years and above. And we realized that the fall from height was realized in the total number was actually 8 patients. So fall from height was realized in 6 patients, and then fall standing height was realized in 2 patients. Now going on to the assault was noted in 12 patients. So the assault type, assault without a weapon. So those who were assaulted without a weapon was noticed in 3 patients. Those who were assaulted with a blunt weapon were noticed in 5 patients. Those who were assaulted with a knife or a machete were noted in 4 patients. So we move now to domestic violence. There was noticed in 3 patients. So for domestic violence, assault without a weapon were noticed in 2 patients, assault with blunt instrument in 1, and then in other cases, like maybe the patient was hit by a foreign object, the patient was an industrial accident, and so on and so forth. So for the mechanism of injury, it is very, very important, because the mechanism of injury too determines the clinical outcomes of the patients and the number of patients that actually suffers from traumatic brain injury. So for the mechanism of injury, a bicycle accident, that's those who were riding the bicycle and then they suddenly had an accident, was noticed in 1 patient. Fall from a higher level, a higher level was noticed in 6 patients, maybe those who are working in industries, and then they suddenly fall from a lever. Fall from a same level, 5 patients. Hit by a blunt object was noticed in 6 patients. The knife or machete was noticed in 4 patients. Motor vehicle accidents in 23 patients, and motorcycle accidents in 111 patients. So this is very, very significant, this motorcycle accidents. So, and as you have seen, the main cause of traumatic brain injury in these patients that were recruited in this study. So move now to the pre-hospital details of traumatic brain injury. Now, pre-hospital details is what happened before the patients before the patients came to the hospital, like how the patients what happened at the scene, how the patients were transported, or if the patients were referred, and so on and so forth. So I'll just move straight to the table, and some patients were referred from health facilities. Some patients were referred directly from the injury side. So those who were referred directly from the injury side, there were 65%. There were 65 patients, and those who were referred indirectly, that's they went to a particular health institution or health center, and they were later referred to this level 1 trauma center. There were 95 patients. Now, for the means of transport of these patients, how were the patients transported, both from that direct referral and indirect referral? So in the ambulance, we realized that only one patient was transported using an ambulance. Seven patients were transported using the motor taxi. 10 were transported using a private vehicle. 45 were transported using a taxi, and the others were transported using 2 patients were transported using other means. And in the patients that were transported using an ambulance, we realized that at least there's a high probability that the patients were actually, they were actually receiving some medical attention, maybe from maybe there was a physician in the ambulance or a nurse or a head personnel that can actually uh, or maybe be doing some first aid on the patient while they are on their way to the hospital. But if you look at means of transport like motor taxi, private vehicle, and taxi, you realize that the probability that there was a head personnel, probability that there was a head personnel actually giving maybe a first aid or taking care of the patient is actually very low. So transport from other health center to trauma center. So for those that were referred indirectly, how were they transported? So 14 of them of the patients were transported using an ambulance, 5 were transported using motor taxi, 15 were transported using private and then that's private vehicle, and 60 were transported using a taxi. General means of transport. So generally the means of transport was medical means was noticed in 15 patients. Non-medical means was noticed in 145 patients. So you can just imagine this can also influence the way the patient will present and the outcomes of the patient clinically, because those who were transported using unmedicalized means will likely not receive any first aid or any or medical care prior to their appearance in the hospital. Now, for those who were transported in the ambulance, was a physician present? No physician was present in 12 patients, but a physician was present in 2 patients. And since the physician was present in 2 patients, it shows that these 2 patients actually benefited from maybe first aid from the physician before they arrived at the hospital. While those who never had a physician beside them while they were on their way to the hospital never benefited from maybe any first aid or so. So vital monitoring were done in 12 patients. Fluid administration was done there was no fluid administration in any of the patients. Airway protection was done in 7 patients. Drug administration was not done. And then now transport position, how the patient was transported. This also matters because a traumatic brain injury, the way you place the patient to will determine maybe the way the patient will be taking air. That's the airway, the breathing, the circulation of the patient. So those who they were lying on the side, like maybe they were lying on their left side or the body or the right side, were 26. There were 28 patients that they were lying on their left side. Those who were just sitting upright, there were 44 patients, and those who were lying supine, like flat, there were 88 patients. So time difference between injury and arrival at the hospital, at the referral hospital. So 39 or in this study, 39 patients actually arrived less than 1 hour. That's after they had the injury, they arrived less than 1 hour to the health facility. 71 patients arrived between 1 to 4 hours, and 30 arrived between 4 to 11 hours, and then 20 arrived between 11 to 24 hours. And remember that one of our exclusion criteria was that those who arrived greater than 24 hours were excluded. That is why they are not mentioned here. So injury characteristics and management. So now the injury characteristics, in traumatic brain injury, maybe the patient can be involved in polytrauma or isolated traumatic brain injury and the other. So they actually study the injury characteristics and the management. So 19% of the patient actually had a polytrauma, which gives a percentage of 12%. Isolated traumatic brain injury, that's those who have isolated injuries, there were 141 of them, which gives the majority of the patients. So the classification now of traumatic brain injury, and as we have seen before, they classify traumatic brain injury. They used the Glasgow Coma scale to classify it. So the moderate mild traumatic brain injury was noticed in 66 patients. Moderate was noticed in 55 patients, and severe was noticed in 39 patients. So we've seen that the majority of patients actually had mild traumatic brain injuries. Now, when on admission, like when they came to the hospital, we would like to monitor the management. Was CT done? That's computerized tomography scan was not done in 35 patients, while CT scan was not done. Maybe voluntarily was not done in 35 patients. Then those that they requested for CT scan, but they could not, maybe due to financial reasons or financial constraints, they could not do it. Was not done in 28 patients, and then those that there were no CT scan was recommended in 7 patients. So reasons why CT scan was not done. So as we have seen, the CT scan was not done in 28 patients. Now, one of the reasons why CT scan was not done, it was due to financial constraints, and and it made a lot of sense because actually the study was carried out in Cameroon, and it's a low and middle income country. So majority of the population is the economic, the socio-economic status of majority of the population is actually very, very low. So this actually explained why majority of patients could not afford CT scan for their management. So others was 10 others could not also afford it, maybe due to reasons the researchers could not identify. So if others move to other hospitals, actually 3 patients moved to other hospitals, then patients that were not asked, there were 7 of them. So complementary exam done characterize injury. So CT scan, if CT scan was done, for those that CT scan or magnetic resonance imaging was done, was 77 patients. So out of the 77 patients, those who had fracture, there were 100 those who had fracture were 125 patients, and out of the 125 patients, fracture was noticed in. So 125 patients they did CT scan, and then fracture was noticed in 36 patients. Linear skull fracture was noticed in 20 patients, or depressed fracture was noticed in 22 patients. Basilar skull fracture was noticed in 19 patients. And the type of traumatic brain injury out of the 77, extradural hematoma was noticed in 22 patients. Acute subarachnoid hemorrhage was noticed in 18 patients. Cerebral contusion was noticed in 25. Cerebral edema was noticed in 10, and meningeal hemorrhage was noticed in 8 patients. So mass effect was also present in 3 patients, and then intracerebral hemorrhage was noticed in 12 patients. The other type of traumatic brain injury was noticed in 4 patients. Now, after the evaluation of these patients, some of them actually did or underwent neurosurgery. So 17 patients underwent neurosurgery, and 60 patients did not undergo neurosurgery. So for the discharge status of the participants, so the median hospital stay for non-operated patient was 4 days. So those who were not operated, they were hospitalized for maximum 4 days, and after which they were discharged. But those who were actually those who underwent neurosurgery stayed for at least 7 days in the hospital. So 21 patients died. 21 patients actually died, of whom 18 had sustained a severe traumatic brain injury. So out of uh, 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 so we realized that majority of the patients who died are those who actually sustained severe traumatic brain injury. So the median time between injury and death was 24 hours. So those who sustained severe traumatic brain injury, they died within 24 hours, and a total of 120 patients were discharged home. So anyway, let's just discuss this using this table. So the total hospital stay, uh, those who were total hospital stay 4 days. Those who were not operated stayed for 4 days. Those who were operated were discharged 7 days after. Discharge destination. Those who were discharged with their homes, like they were discharged and they were sent directly to their homes. There were 126 patients. those who were discharged to rehabilitation center, maybe they should, those who were discharged to rehabilitation center, maybe to undergo physiotherapy. Also, there were 4 patients. Those who were discharged and they were sent to other hospital facilities, maybe internal medicine facilities, uh, or or other facilities were 8 patients. Those who were discharged against medical advice, maybe due to financial constraints, they could not actually keep up to, or they could not afford their medical bills or their upkeep in the hospital. So they were discharged, and there were 46 patients who actually fell in this particular group of patients. So we look at the reasons for the discharge against medical advice. So financial constraint was one of the main reasons, and of course it makes sense because this study was done in low and middle income setting. Then those who decided to seek traditional treatment, there were 8 of them, and then there was no readmission. So outcome at discharge, disability rating scale. So the recovery status, those who extreme vegetative state, there was 6 of patients. Vegetative state, there were 3 patients. Extremely severe disability, there were 7 patients. And then severe disability was seen in 8 patients. Moderately severe were 26 patients. Moderate was 28 patients. Partial disability was noticed in 27 patients, and mild disability was noticed in 9 patients. Now, 25 patients actually recovered, and the mortality was 21. Those who actually died, it was 21 patients. So the mortality now, according to the TBI severity, that's mild traumatic brain injury. Those who actually had only 1 patient who had mild traumatic brain injury actually died, and those who had moderate traumatic brain injury, only 3 died, and those who have severe traumatic brain injury, only 7 actually died. So for the 6 month outcome after hospital discharge. So after this patient was discharged, remember it is a prospective study. So after these patients were discharged, they were actually monitored through, for those who were living in far away areas, they were monitored through telephone or line, that's through direct interviews with the patients and with the family members. So after 6 months, 25% of the patients had an unfavorable outcomes. So 25% of patients, the outcome was not favorable. 75% had a favorable outcome, and which was actually a very good thing to notice as far as this research is concerned. But the one patient who actually signed against medical advice died upon discharge, so increasing the overall mortality rate to 14%. That's 22 patients. So initially we saw that 21 patients died, both from severe, moderate, and mild traumatic brain injury. But the one patient who actually signed against medical advice died, so increasing that mortality rate to 14%. Or So we'll move to comparison of 6 months traumatic brain injury outcome and time difference between injury and arrival. So the type of injury and CV severity. So actually, the researchers, those who did this research, they discovered that there was no statistically significant difference in outcomes comparing traumatic brain injury severity and arrival at the hospital. So there was no statistical significance. So it means that in this their study, or they could not actually get a correlation, like, or there was no significant difference in outcomes comparing traumatic brain injury severity and arrival at the hospital. So the time which they arrive at the hospital and the outcomes of the patients, there was no significance. Like, the time they took before arrival on the hospital had no impact on the outcomes of the patients. But likewise, the researchers found out that there was no difference between direct or indirect referrals and discharge outcomes in the disability rating scale. So as expected, a statistically significant correlation was seen with the injury severity and the outcomes. So discharge and 6 months for the disability or rating scale. So that is it for the results that they had. Let us just have a flashback on our review template. So is the data presented in appropriate way, like the tables and figures relevant and clearly presented? Of course, I think their findings was clearly presented as we have seen on the tables, and the tables were relevant, their findings were cleared, and it was actually cleared. So appropriate units, rounding, and numbers of decimals. Actually, as we have seen, the appropriate units were used, those for percentages, and the decimal points, the rounded up were actually respected. The titles, the columns, the rows labeled correctly and directly. Yeah, so the results, as we have seen, the way they presented the results is actually is in line with the review template. So we have seen the titles, we have seen the columns, the rows, and the various data that they inserted in uh, the various columns and rows. Categories group appropriately. Yeah, so the categories of all the data were grouped appropriately, beginning from the age and the others we have already seen. So does the text in the result add to the data, or is it repetitive? Well, I think the text in the result it adds to the data, as we have seen, especially here. As we have seen, especially here that they said the statistically significant correlate was seen with the injury severity and outcomes. So the outcomes of the patient and the outcome, the severity of the injury of the patients and the outcomes were actually correlated. There were a statistical significance in between. So the next was, are you clear about what is statistically significant result? Uh, for this, I am not actually that clear. Maybe we'll discuss about it. Then the last part, they will say that, are you clear about what is practically meaningful? Is a practically meaningful result? Oh, well, yeah. In this study, the practically meaningful result here is, as they are trying to see the outcomes, the characteristics, the outcomes of these patients throughout this period of 1 year that they monitor the patient prospectively. So so the results were, for me, I think the results were meaningful, and for me, I think the results were actually meaningful, and I think we'll discuss more about it. Maybe we'll share ideas, and then we'll see into it. So that is it for the results, and let's dive into the discussions, and then that will be all. So for the discussions, the study actually presented characteristics of traumatic brain injury and outcomes of at a level 1 trauma center, as we have already seen in Douala, Cameroon, and also with the aim of identifying meaningful or identify measures to improve traumatic brain injury prevention and care. So as we already saw, even at the level of the abstract, they are forecasting that the incidence of traumatic brain injury is going to increase by the year 2050. So this research is actually very, very important, in the sense that the findings in this research we try to guide or to direct health policies on how they can better manage, or how they can implement some preventive measures to decrease the incidence of traumatic brain injury, not only in Cameroon or in sub-Saharan Africa, but in the entire globe. So one thing for the demographic and injury characteristics, actually 160 traumatic brain injury cases were reported as we have seen, and majority were aged between 15 to 45 years, and predominantly the population in this age group was made up of males, consistent with other reports from low and middle income countries, as it was cited in this reference 20 and 21. Also, most of the participants, that's page 122, had no had not finished secondary education. So they also realized that maybe the level of education can also impact, you know, uh, the exposure of the patients to maybe road traffic accidents, assaults, and others leading to traumatic brain injury. As noted by Aston that's which was cited in the reference number 22, and Amran LR, which was cited in reference number 22, no educational levels constitute one of the specific risk factors for road traffic accidents and assaults, and are greatly is understudied in low resource setting. Of course, those whose level of education are actually very very low. Majority of those who find themselves doing these menial jobs like manual labor or motorcycling as their profession, and so on and so forth. So road traffic accidents were main cause of traumatic brain injury, as we have already seen in 85% of the patients that were included, and often involve commercial bike riders, as of course as we have seen. And I'm sure majority of the commercial bike riders are those who are of low educational levels. So in Cameroon, many youths are involved in hazardous occupational activities like commercial bike riding, as better jobs are difficult to obtain, and this is also due to the fact that most of the youths are not even their educational level is not really that advanced. They are not well educated that they can be exposed to white collar jobs. So they find that themselves doing these hazardous jobs like motorcycling and the others. So as such, they are exposed to to road traffic accident and subsequently traumatic brain injury. Then these young citizens are frequently involved in commercial bike riding, often without helmets. Yeah, the aspect to that most commercial bike riders don't use helmet also increases the severity of the injury. Like those who never had a helmet on, those who never had a helmet on will likely have it moderate or severe traumatic brain injury. So in contrast to low and middle income countries, falls are the main cause of traumatic brain injury in developed countries, as cited in the reference 26 and 27. Yeah, in high income countries, most of the youth population, they don't find themselves doing, or some of the jobs that some of the youth in low and medium income countries find, like maybe motorcycle. Most of the youth in high income countries, they find themselves exposed in, you know, in white collar jobs. So as such, you see that majority of those or those reported cases of traumatic brain injury are uh, those who are of age greater than 65 years of age, and that constitute those who are not even part of the working population. So this difference in the causes this difference in the causes observed can be explained by the fact that high income countries have better road infrastructures and implementation of safety road practices. So this point is also very very important. And of course, the road infrastructures in high income countries cannot be compared to the road infrastructures in low and middle income countries. And as such, the rate of traumatic brain injury is high in low and middle income countries than in high income countries. Now, many of the traumatic brain injury patients involved in the road traffic accidents were drivers without a license. Yeah, most of the patients, some of them were not even educated. Some of them they did not even take out time to maybe go to a driving school to obtain some driving skills. And since we are even in low and middle income countries, due to financial constraints, some of them cannot even afford to afford to enroll into a driving school and to get the necessary skills of to drive safely using the road. So this high percentage of motor vehicles and motorcycle drivers without driving licenses is in line with the Cameroon government's 2019 statistics, where 70% of road traffic accidents were reported to originate from human causes. So human causes like alcohol consumption, or those who not those who have not obtained or training in driving and so on and so forth. So the causes include lack of driving license or illegal driving license. Like we are in low and middle income countries, and it is possible that or some of the motorcyclists can actually have licenses illegally. They can pay and they have the licenses, whereas they have not undergone the training. Now, the low socioeconomic status of traumatic brain injury patients could explain the relatively high discharge against medical advice cases. Of course, if if you are in the low income class patients, they don't have the finances that they can use. They don't have the necessary finances that they can use to actually finance the medical care. And we should also note that traumatic brain injury patients, the cost of hospital care is actually expensive, and it is not easy. So majority of the patients who are of low socioeconomic status will sign against medical advice because they cannot afford the medical care. Moreover, the majority of the citizens are not insured. Of course, they don't even have, or they are of low economic status, and they cannot actually pay for insurance in any insurance company around. So more than half of the traumatic brain injury victims were alcohol consumers, as you have seen, in 61% of the patients. And this corroborates to a study in Cameroon that reported high alcohol consumption rate of 41% of men and 25.8% of women. And this was cited in reference number 30. So the result, however, differs from the study of Wakabayashi in Thailand. Of course, in Cameroon, as we have seen earlier, majority of the patients that were enrolled in this particular study were Christians. Now, in our African setting, in fact, in Cameroon in particular, 80% of the churches they don't preach against alcohol consumption. So that's why I see that majority of those who are Christians, they are also alcohol consumers. But this contradicts the study that was done in Thailand, because in Thailand, majority of the religious institutions there, they restrict alcohol consumptions to the Christians. So as such, in Thailand, you cannot have alcohol consumption as one of the causes of traumatic brain injury. So moving on to pre-hospital care and post acute pre-hospital care and post acute acute care. So the result of our study of this study are highly illustrative of the specific challenges and disparities in care in low resource settings. So the disparities actually is really the gap in care is really huge, starting from the low socioeconomic status of the patient to even the resources, the instruments in the hospital setting, the we're talking here about the hospital care, hospital stay for these patients. So as we have already seen above, those who were not operated were discharged after 4 days, and those who were operated were discharged after 7 days. And only 4 of among these patients were referred to rehabilitation centers for physiotherapy, massage, and the others. But unfortunately, active physiotherapy services were not recommended for hospitalized patients with disabilities, as there as there are no services as there are no local standard for physiotherapy referral for TBI patients. So such therapy is recommended in enhanced recovery. The lack of appropriate post-acute care constitute a major problem in the care of traumatic brain injury patients, especially in low and middle income settings. So the disparity gap is the gap of care of post-trauma care is really, really large, which may greatly impact the outcome of traumatic brain injury patients. So active physiotherapy services in traumatic brain injury can deliver better functional outcomes in sub-Saharan Africa, and implementation of this should be high on the policy agenda. So majority of these patients, as we have already seen, only 7 of them were even referred for rehabilitation. That's the rehabilitation center, and they are saying here that physiotherapy actually greatly increases the the outcome of the patients after the injury. So patients who don't undergo physiotherapy, they are likely going to have unfavorable outcome after the injury. So we look on the disparities in care due to financial constraints. As we have already seen above, we are already in low and middle income countries, and majority of the patients, I think about 120 or so, had some financial constraints, and as such, some of them even withdrew from care. There are some of them signed against medical advice, and some of them who even had the opportunity to stay and receive some the medical care were unable to even afford computerized tomography. So the disparities in care is really, really broad due to the financial constraints of the patients. And the disparities is also in accordance with some of the the research or the studies that have already been done so far as this study is concerned. Like they are saying here that 46 patients were discharged against medical advice with financial constraints as the main reason. This rate of discharge against medical advice in is much higher than the reported rate in high income countries of 2.8%. Of course, in high income countries, we don't expect patients to to sign against medical advice or discharge against medical advice, because they have the facilities, and majority of the patients are they are high income patients, and their economic status is actually good as compared to those who are in in sub-Saharan Africa, in fact in low and middle income countries as a whole. So the rate of discharge against medical advice in the high income countries is very, very low. And this is in accordance with a study that was done by Kim that's was cited on reference number 39, Gibbs reference number 40, and Marcus reference number 41. So discharge against medical advice cases are disproportionately high in low and low income countries, like low income countries setting like in Cameroon, of course. So furthermore, the observed rate of 33% is likely an underestimation of the true financial constraint in treatment after TBI in low resource settings. Some traumatic brain injury patients without financial means remained in the hospital as their family members tried to raise the necessary funds. So it was really a challenging issue for some of the patients. So some of them who persevered and did not sign against medical advice, even after the number of time we were supposed to spend in the hospital, they were not released due to the fact that their medical bills had not been paid, and their their family members has to to struggle and look for the necessary finances to pay for their medical bills. So two patients two patients registered in this study Two patients registered in this study received treatment and were later not permitted to leave the hospital, due to the unsettled the debts, of course, due to their financial constraints. So this situation likely caused psychological distress and negatively impact their recovery, as suggested in literature. As this was also suggested, or this was in line with a study that was done and was cited in the reference 42 to 44. So findings from this study revealed that survivors of findings in this study revealed survivors of those who were discharged against medical advice cases were more likely to have disabilities and a poor quality of life 6 months after injury. So even those who signed against medical advice and they survived, but they also encountered some disabilities and some poor quality of life uh, after 6 months. That's after the study was being conducted by the researchers that actually did this study. So there's a diagram here that I don't know if you can see. There's a diagram here that is disruptions in the chain of trauma care, starting from emergency medical services. So we realize that for the emergency deficient, only one patient taken from the incident side actually went to the hospital through an ambulance. We also had disparities in CT scanning. For example, some of the patients could not afford computed tomography. Some of the uh, some of the patients they were not recommended to do CT scan and so on and so forth. Then discharge against medical advice. Of course, some were discharged against medical advice due to the fact that they were unable to pay due to financial constraints, they could not pay their medical bills. Of post-care or post-acute care, also there was disparities in post-acute care, as was seen only 4 patients received physiotherapy after discharge, and no patient received physiotherapy mobilization in hospitalization. So this is saying that when they were actually in the hospital, none of the patients received physiotherapy, but only 4 patients were actually referred to rehabilitation center so that they can receive physiotherapy. So the disparity in post acute care is really high. There's a huge gap in the post acute care as compared to in low and middle income countries and as compared to the high income countries. So for the overall outcome, mortality occurs in The mortality occurs in 22 patients. So initially 21 patients died, and the one that signed against medical advice, as we saw already, that one that signed against medical advice died, making 22 patients, consistent with the two. And this constituted 14% of the overall patients that were recruited for this study, and this was consistent with the 10 to 24% mortality reported by Pelio R, in which was cited in reference number uh, reference number 45 in this study in Switzerland, Tesfa R in reference number 34 in Ethiopia, and Menia R in reference number 21 in the Middle East. The median time between injury and death was 1 day, of course, less than 24 hours, much lower than reported in the study of Gaio R, which was which was cited in reference number 46. Then where mortality occurred within 14 days. Yeah, but we should also remember that this study was also included only those who were traumatic brain injury in patients less than 24 hours. So this difference can likely be explained by the exclusion of cases that died at the emergency service in the study by Gale and also by the higher healthcare standards in China and compared to Cameroon. The mortality rate of severe traumatic brain injuries victim is in this study is was 46% and it was the highest because I think about 18 patients out of the 22, 18 patients also died. 18 patients who died actually had severe traumatic brain injury. Yeah, this is 18 on the 35 patients. Is disproportionately high compared with high-income countries, which was in accordance with low AR reported. Low AR, which is cited reference number 47, reported a disproportionately high compared with high income countries. So this higher death rate with severe traumatic brain injury in low and middle income countries will be explained by little or no pre-hospital care. Of course, we have already seen how the patients were transported. The majority of them were transported using unmedicalized means. Some of them were transported, some that were even transported using medicalized means. There were no personnel in place to even take care of them, like maybe give some, some first aid prior to their arrival at the hospital setting. So limited resources and financial constraints faced by patients to obtain the necessary health care and necessary health care was also another reason why the majority of the patients died of severe traumatic brain injury in low and middle income countries as compared to those who died in high income countries. So the 6 months Glasgow outcomes scale extended showed that 44 patients had an upper good recovery. That 44 patients had an upper good recovery, 21 had an upper moderate disability, and 12 had an upper severe disability. That's those who had severe disability. And this was consistent with reports from Paris, France, which was cited in this article on reference 49 and Tanzania reference 6. Dumbe R, Dumbo et al., which was cited in reference 14 from Cameroon, noted that only 12.6% of patients fully recovered and 55 of these cases had permanent disability. So those who really fully recovered, they had permanent disability. However, only severe traumatic brain injury patients were considered in this study for those that had permanent disability. So the strength and limitations of this study, where this study was actually one of its kind in Cameroon, and that is one of the strengths because there was a gap in the data as far as this particular aspect of traumatic brain injury in Cameroon is concerned. And another thing another strength of this paper is that is a prospective or a prospective study, given that the fact that they receive the patients, they monitor the patients over a period of time, which is in this case was 1 year, rather than a retrospective study. So this prospective study it further strengthen the impact of this particular research. For the limitations, I think this particular study was conducted only in one trauma center in Cameroon. So I think if this study was conducted in maybe let's say 3 trauma center or 4 trauma centers in Cameroon, maybe in 4 different hospitals, maybe in 4 different major cities in Cameroon, and then they group the study, they come out the result, and maybe you can better give an idea on how the characteristics and outcome of traumatic brain injury is in Cameroon at large. But nonetheless, I think this study it gives like a map of how the outcomes, the characteristics and the outcomes of traumatic brain injury is in low and middle income settings like in Cameroon. So for the conclusion, traumatic brain injury in Cameroon commonly occurs in young males of low educational or low educational and socioeconomic status, and as we have already seen, because these are the age group that are more involved in some of the hazardous practices. So some of the hazardous activities like manual work and road transport like motorcycling, vehicle, and the others. The main cause of traumatic brain injury in Cameroon is road traffic accident, as we have already seen so far, and the mortality in patients with severe traumatic brain injury is disproportionately high compared to high-income countries. And we have already seen why it is high, because there is a lot of disparities starting from the low socioeconomic status of the patients, moving towards or before, we also have the facilities, the specialties, the expertise in place to take care of the patients, and so on and so forth. And also the the road infrastructures of the road infrastructures in low and medium income countries as compared to high income countries. So that is why the mortality is bound to be high in low and medium income countries as compared to high income countries. So these studies also report the deficiency in pre-hospital and post-acute care, as we have already seen, starting from how the patients were transported to the level one trauma care center, and the presence of health personnel or that's when prior to admission at the hospital, and so on and so forth. But I'm sure in high income countries, you see that the road infrastructures are perfect. You see that majority of the patients will be transported using ambulances, and there will be medical personnel in place to maybe give or maybe a first aid, take care of the patients while on their way to the trauma center, and that helps to reduce the mortality of the patient in high income countries greatly. So implementation of universal health insurance may insurance may be expected to improve hospital care and outcomes. Like if they implement that, at least maybe majority, if not all of the motor cycle, that's the bike riders, those who are using the road for commercial transport, that majority of the road users should be insured. Majority of the road users should be insured. Majority of the road users should uh, you know uh, undergo training, that they should get a driving license, a legal driving license from a school that is being recognized by the government, and that is will help to reduce the outcomes of traumatic brain injury in Cameroon, and also reduce the number of discharge against medical advice cases. So road traffic safety and the prevention of road traffic incidents should be high in the policy agenda. So due to all what the researchers have found, that's out of the 160 patients that they included in this study, due to what they evaluated and the outcomes of the patients, starting from the cause of the traumatic brain injury, the 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 age group of the patients, the educational level, and other socioeconomic factors, they can see that it can give an idea on the major aspects that the government can implement. That's the health policies that the government can implement in order to reduce the incidence of traumatic brain injury in Cameroon, and even in sub-Saharan Africa, and in Cameroon, sub-Saharan Africa, and even in the world at large. So that is it for the conclusion. And then we also have our references here. Yeah, the references are, as we have seen during the presentations, the references were actually the references were relevant. Most of the references were in accordance to the findings in this study, and they were of recent too, like, and they were of recent, and some of the references are even what has been done in Cameroon. There are some of the studies that have been done in Cameroon with respect to traumatic brain injury. So that is the end of my presentation. Thank you so much for your keen attention. So
So, uh, sure we are just the three of us or the two of us, but there have been some questions which have been dropped in the inbox, and the first one reads, I don't know if you can see it, but for the sake of everyone, I will read it out. So the first question is from Lorraine. Actually, there are three questions from Lorraine. The first one is based on the study. We can also query if the author or the authors considered discussing potential culture or societal factors that may contribute to the high incidence of TBI in Cameroon. So I don't know if this was a statement. I think you can put a comment on this one on the first. I don't know if you can see the comment. So I think you can comment on that.
Okay, Doctor. Thank you so much, and thank you so much, Dr. Lorraine, for this question. Yes, I think as you have seen in the study, some patients were discharged against medical advice because they diverted to traditional treatment, traditional medication. So, yeah, they diverted to traditional medication, and I don't think traditional medication will really help in the case of traumatic brain injury. And also, one setback that I realized in this study is that the patients that were discharged against medical advice, I don't know, they were like so the patients that were discharged and they decided to to divert to traditional medication, they would have followed them up to see how the patients or the outcomes of the patients, if maybe the traditional medications were beneficial, and if the traditional medications were beneficial, they can maybe see if maybe or they can also implement it, and they can also implement it like like a means to treat traumatic brain injury patients. Uh, so the cultural aspects, they did not really stress on it, but I think the fact that the patients diverted to traditional or medications we actually influence their outcome, and I think the outcome will not be favorable. So that's what I can say for concerning that. I don't know if maybe someone else has something to say about it.
Oh, all right. So I think the question was about the potential cultural or societal factors that may contribute to the high incidence of TBI, not necessarily as in the traditional medication, but some
Um,
cultural causes that may
okay,
contribute
okay,
to the
okay.
high. Sure.
Oh, okay, okay. Okay, okay. I see. Yeah. Social factors. Yeah. We have seen in this study that some of the patients were alcohol consumers, and I think that's a social factor that we can include here. Some of the patients were alcohol consumers, and with alcohol consumption, it's not safe. It's not safe for someone to let's say you are a regular road user, and then you consume alcohol regularly, and maybe you are even drunk and you are using the road is actually bad. So I think the societal factors, this concerning alcohol consumption, that is more of social, but cultural or societal factors that may contribute to the high incidence of traumatic brain injury in Cameroon. Uh, well, like I explained before, I think the cultural factor is that because so that there are some people that are so inclined in their culture that when they are suffering from a particular disease or medical condition, they like to revert to traditional medicine, and they think that the traditional medicine can actually help them to cope their disease. So that's what can the traditional factor can actually influence the incidence of traumatic brain injury. Well, well, I don't know how I can better address it, but so far that's my own idea about it. But it's a very, very good question. It's a very, very good question. And it's something that maybe the researchers too did not actually put in consideration, but I think it's also very, very important.
All right, thank you. I think you can just put a comment on the remaining two questions from Lorraine.
Okay.
Yeah, you can just put a comment there, sure.
Okay, the next question is that it is also possible that the sample size of patients in the study may not be representative of a larger TBI population in the country. Yes, doctor, thank you very much for this remark. Like I said during the at the end of the presentation, I said that they did this particular research work only in one trauma center, only in one trauma center. That is one major setback in this study, because I don't think doing it like this will give a general picture of the characteristics and the outcome of traumatic brain injury in Cameroon as a whole. So it would have been better they did this study in maybe at least 4 or 5 or trauma centers at the same time. And doing it like that, we also increase the sample size, because here they used 160 traumatic brain injury patients. So if hadn't been they included the number of centers in which this study was carried out, you will see that the sample size will automatically increase, and that is going to give a big picture of the characteristics and the outcome of traumatic brain injury patients in Cameroon. So that is, I think, this is one of the so if you increase the sample size of these patients, the best way is to, I don't know, maybe subsequently they can do a research or a research focusing on this topic, or maybe they can divert it to something else but related to the topic, and then they can increase the sample size, the or the number of trauma centers, so that you can give a good picture. So that's one of the major demerits of this paper. So that's it. So if they want to increase it, maybe they can do it subsequently in a different or in a different study, because this one has already been done, and as we have seen, it has already been published. So I've answered, if my concerning the second question is okay by everyone, or maybe
All right.
somebody have something to say about or a contribution to make.
I don't think so.
Okay, all right. The last one is the paper in overall definitely has merit. It succinctly demonstrated the burden of traumatic brain injury, the disparities in patient care, highlighting the challenges and directing future research. Yeah. Actually, thank you so much, Dr. Lorraine, for this remark. So the paper has a lot of merit. It has a lot of merit. First, in the fact that the study has not been, a prospective study of this type has not been done in time. And then it also highlighted some of the disparities as compared to, as compared to high income countries. And this particular article too can also serve as a guide for public health policies, if they want to maybe reduce the incidence of traumatic brain injury, and they can use some of the findings and the conclusions or recommendations as a guide to cope or to reduce the incidence of traumatic brain injuries in Cameroon. So I think it's a good paper, and something can be done in the future too. That's a further research about the topic. So the paper is reproducible. Let me say so. So
All
that's
right.
my remark. My remark about.
All right. Thank you very much, Becklin, for this long yet insightful presentation. Wow, it was really insightful and educative. Yeah. So just hoping that future maybe we can try to adhere to those comments which are made and the corrections. I don't know. Yeah, but I think to my end, unless there is any further questions, if there are no any other question, I think from my end it's a good night. And since we've never started with a prayer, I don't think it would be wise to close with a prayer. Yeah, so thank you very much once more, Becklin, for this wonderful presentation. I think it's a good night now. Thank you.
Okay, thank you for making such a wonderful program. And sorry I could not do a PowerPoint separately to present it. I realized I had to do a PowerPoint was really late, so I decided to just present as I did. So maybe in future I'll see if I can do a PowerPoint and then we'll flow like that with it. So thank you so much for the privilege and also for coordinating this particular session.
All right, sure. Thank you.
Okay, see you later.